Good morning, good afternoon, and good evening, everyone. Welcome and thank you for joining us for today's second webinar in our four-part series, More Health for Today's Money. As people continue to join the call, I see we already have quite a number and the number's going up. Let me cover just a few logistics before we really start. Next slide. Next, this one, yes. So you'll see we're on Zoom today. First, for our Francophone colleagues, we do have simultaneous interpretation into French today. You can click the globe icon and select the French channel to listen to the interpreters. Tout d'abord, pour nos collègues francophones, nous avons l'interprétation simultanée aujourd'hui. S'il vous plaît, cliquez sur l'icône du globe et sélectionnez le canal français pour écouter les interprètes. Et si vous ne voyez pas l'icône du globe immédiatement, cliquez sur More ou Plus et vous devriez le trouver là. Thank you. Second, please use the Q&A box today to pose any questions or comments to our panelists. They won't see the chat necessarily. We will not have a live Q&A, but we'll answer as many questions as we can in the Q&A box. We have a whole team dedicated to that, and pose some to other panelists. We will also have some questions for all of you via a few Zoom polls. You are welcome to use the chat box to introduce yourself and flag any operational questions to our team. Lastly, again, I said it in French, but if you do not see the Q&A or the globe interpretation icons immediately, you can click on More and they should be there. Next slide. So welcome everyone. Again, my name is Nathan Blanchette and I'm a program director at Health Systems Insight, formerly known as ThinkWell Institute. I'm very pleased to moderate today's webinar, which is the second in a four-part series organized by HSI's Strategic Purchasing for Primary Healthcare project with support from the Gates Foundation. I will share some brief opening remarks about the series and our plan for today, and then we'll move into our planned discussions. We have about 90 minutes planned. Next slide. So let me start by a brief recap of the context. We talked about this in our first webinar, so I'll be brief. But I do want to recap the motivation for this series. We know that resources for health are always scarce, but today financing is under increasing pressure from at least three sources. First, governments face rising fiscal pressures from debt and inflation, and evidence shows that this is leading to declines in public health spending. Second, we all know external development assistance for health is also declining dramatically. Many of you may have heard a stark summary of these cuts from Susan Sparks of the World Health Organization in a health financing webinar last week, hosted by the GFF and World Health Organization, where she cited a 23% drop in ODA from 2024 to 2025 and projected declines of 19 to 33% in bilateral health aid. These declines in funding are exacerbated then by increasing demands actually on primary health care from growing populations, chronic disease, pandemic risks, climate change. Together, you can see on the chart here on the right that the World Bank projects significant shortfalls relative to the minimum public health spending that would be needed to attain universal health coverage benchmarks. In low-income countries on the left side of the graph, you can see the shortfall underneath the minimum of estimated $60, and lower and middle-income countries on the right, with projections falling short of that $92 benchmark. All of which together paints a very constrained resource environment. And I think we likely all agree that more money for health is needed, but our focus today is that it's also vital that existing resources be used as efficiently as possible. So responding to that context, and next slide, please. This we the SP for PHC team has reflected on 7 years of experience across 6 countries: Burkina Faso, Indonesia, Kenya, Pakistan, the Philippines, and Uganda, where we've worked with governments and other partners to strengthen primary healthcare financing under real-world constraints. When we focused on what we've learned about generating value with scarce resources, we really concluded and wanted to highlight in this series 4 interlinked priorities. In the first webinar, you see in the swirl in blue here, we started at the district or county level, focusing on how managers can more strategically resource primary healthcare with better data about their existing resources. In this second webinar, we're now moving to the national level and focusing on the coherence of national purchasing programs and how they can support or sometimes unintentionally distort primary care delivery. The third webinar in about a month from now will examine fund flows from national to facility level and how various bottlenecks, delays, rigidities can shape what primary healthcare facilities can actually achieve. Finally, the fourth webinar will build on the principles from the first 3 and apply them to a part of primary healthcare we all recognize as vital and in need of innovation. And that's how medicines and supplies are financed. So together with our partners and our experience over the past several years, we are confident that each one of these is individually valuable to generate more value with scarce resources. But we think it would be especially valuable if countries seize opportunities to work on all 4 of them together. So that is what this webinar is about. Next slide. I'll be very brief here, but for those of you who weren't able to attend the first webinar, I just want you to know some key takeaways. There are more, the full webinar is on our HSI YouTube channel. Perhaps one of my colleagues could put that link in the chat. And our website also has a lot of related materials. So if you missed it, you can get the details there. But very briefly, this explored how better information, particularly on facility inputs, can support more strategic allocation of resources and management decisions. So we talked about how visibility into those inputs helps managers diagnose and act on the drivers of performance. We talked about some lightweight integrated data tools and some innovative potential opportunities to scale those tools in a lightweight, feasible way, such as the health facilities profile module in DHIS2. We also talked about the importance, and we will continue this probably today, of a governance question, which is that information is really only valuable when decision makers have the mandate to act on it. So roles and responsibilities and authorities are very important for this. Okay, so with that, moving into today's webinar, here is our agenda. We will zoom out to the national level and focus on how countries can make mixed purchasing schemes, which is the reality in many countries, more coherent and therefore more efficient. I'll provide a brief framing and then we'll move into a set of country case studies from, as you can see on the agenda here, Burkina Faso, Kenya, and Indonesia. These will help ground our experience, and then I'll provide a little bit of framing that helps structure the dialogue a bit more. My colleague, Pee Wee Ko, will then moderate a discussion with 2 very esteemed panelists, bringing in perspectives from the Philippines, Ghana, and those panelists' broader experiences across Asia and Africa. We'll close with a few reflections, and then move on later on to the rest of our webinar series. We have a very large audience today, but we do want to hear from all of you. We can do that in 2 ways. One, we have some poll questions integrated throughout the webinar to hear from you really quickly. And we also have the Q&A box. That was actually a very rich sort of platform for dialogue and questions and answers last time. So we hope it will be just as rich this time. Please put your questions there and we'll try to get to them. Finally, yes, all materials, including the slides, the recording from today, and some related products will be shared with everyone who registered for the webinar in about a week's time once we clean everything up. Okay, I'm nearing the end of my introduction. Thank you for being patient with me. But before we really move on, one more introductory set of comments to make is on some definitions and assumptions. I want to briefly pause on these key terms. We will talk a lot today about strategic purchasing, and a lot of times we are presuming that to be strategic purchasing, which is the process of making deliberate, evidence-based decisions about how to use health system funds, and particularly deciding what services to buy, for whom to buy them, from which providers, and how those providers are paid. We're also going to talk about coherence. And by that, we mean the degree to which different purchasing mechanisms in a health system are aligned and coordinated so they avoid inefficient overlaps, gaps, conflicting incentives, and instead work efficiently together to support health system goals. We do distinguish coherence as being a broader concept than another one you hear a lot about, which is integration, which tends to be used for the more formal institutional consolidation of different pooling mechanisms. So we're using coherence as a broader term that can be applied across various functions, across various streams of funding or delivery channels. And finally, we are making an assumption today that this is all worth talking about in this climate today, and that is that improving coherence across purchasing schemes, while by no means isn't the only strategy, it is one useful approach to help achieve primary healthcare goals with scarce resources. We think it is especially important to look at this in today's health financing context, where some new opportunities may be opening. All right, great. Um, so moving on now, we've got objectives for today. We're going to start with a bit of what. We're going to have three country presentations to talk about how mixed purchasing manifests in three different contexts. The so what will be a little bit of a how to structure this with a very simple and probably familiar framework to many of you that we think can help dialogue about this. And then we hope our panelists are especially going to help us decide what to do about all of this now. Next slide. Okay, so moving into what we're learning from countries, before I turn over to the presentations, if we go to the next slide, we would like to hear from you to motivate this discussion and start getting into the details here. We're going to launch a poll. We'll just give you a quick 2 minutes to finish it, and it has two questions. So one, in your country, how coherent, given the definitions I've just given, overall, do you think purchasing of primary healthcare is? So I'll give you a few seconds. I think we have to do this one at a time. So I'll give you a little bit of time for this first one before we move to the second. Okay, maybe we can move to the second or show the results of this one. Okay, so I see a mix, a lot of moderately. So room for improvement for sure. Very few extremely. All right, next question is, when you think about any lack of coherence, where does that lack of coherence mainly arise? There's probably many sources. We've put four big ones that we think might be important here. We can launch that poll. If none of those fit your first thought, you can choose other. Okay, let's go ahead and see our quick results. Okay, very interesting. Actually, no one chose other. And let's see, the highest category I'll point out, and lack of coherence from perhaps national health insurance or other purchasing programs versus the usually Ministry of Health centered budget. Okay, great. So with your brains fresh on that topic, it's my pleasure now to move to our country presentations. And we will start with my colleague, who is the West Africa region representative for Health Systems Insight, based in Burkina Faso, and Marie-Jeanne Ofose. Marie-Jeanne, over to you.
Thank you very much, Nathan, and thanks to all the participants to this webinar. I'm very honored to be the first presenter and present about Burkina Faso. Next. So Burkina Faso has a population of 24 million. The PHC per capita spend is around $40. And we have several purchasing mechanisms which are used in country for PHC. Today, we will focus on the gratuité program. So French meaning free is the government national fee exemption program. So the program was introduced to remove financial barrier to maternal and
Marjan, we may have lost your audio and video. I think you've frozen.
uh, can you hear
That's
me?
Yes, we can hear you. I think Marjan, maybe to be safe, we'll have to turn off video if it's a bandwidth issue. Let's give Marjan just a second, see if we can get her back. I might give a little warning to my colleague Kazungu from Khemri Wellcome Trust. If we have ongoing issues with
For that,
Marjan's
I think
connection, we might go back. Okay, Marjan, you're
I
back?
should turn off. Can you hear me?
Yes, we
So
hear
I'm
you.
going to turn off my video.
Yes,
Yes, I think
sounds
it's
good.
better. So sorry for that. Yeah, bandwidth problems. Oh, okay. So I was saying the program, how the program works. Women and children under 5 receive free of charge services in health facilities, and these health facilities get reimbursed by the government the cost of the services provided. So the scheme was rolled out by the government first in 2016, focusing on MNCH services, which are free. And then in 2020, the government added free family planning services. So the program is designed to complement existing fee-exempted services in the country. Generally, the priority programs, immunization and other things which were already free of charge to the population. So the payment is made to the facilities. For the hospitals, is made directly to the hospital, but for the primary health centers, the payment is made through the district. So gratuité has contributed to amazing results in Burkina Faso. We have seen an increase of service utilization regarding maternal and child health services. Gratuité has also contributed in a steep decline in under 5 child mortality. And we have seen also improvement in equity of access to first ANC in the first semester with women. Nevertheless, the schemes still have some challenges. We have growing debts. In 2024, it was estimated at 90 million, the amount US dollar, the amount that the government owed to health facility. With that, we have recurrence or stock out of drug, which leads to families having to incur out of pocket for children or women to have full treatment under the gratuity program, which is not what the program was intended for. The program was intended for beneficiaries to receive consultation, hospitalization, and drugs out of charge. Next, please. So the gratuity program is implemented by the ministry alongside with other purchasing arrangements. One additional implemented by the ministry, and we have another Ministry of Health, sorry, and another implemented by the Ministry of Labor, and we have out of pocket. So there is a clear boundary in people who covered by each program. So Gratuité covers children under 5 and pregnant women. And the government budget line item is universal. But as mentioned before, in terms of service package, there is complementarity. There is no overlaps. Gratuité will cover preventive and curative care for this target group, pregnant women and children, but doesn't cover what is already paid for or provided under the priority program. Gratuité is implemented primarily in public facilities. And as we mentioned before, it's the reimbursement of user fees foregone by facility. While the other Ministry of Health scheme, the line ministry item, support and provides payment of salaries, drug, and other operational costs. So beside those two main purchasing arrangements under the Ministry of Health, we have the National Health Insurance Scheme, locally known as RAMU, which is under the Ministry of Labor, which covers all the population, except that facilities should not claim for the gratuity population, which are children under 5 and pregnant women. And then facilities are paid by the RAMU, 80%, and the user will support the 20%. So as said, there is a clear boundaries in what each of the scheme does in terms of people that are covered and service that are provided. I have to mention that the RAMU is quite recent, though it has been planned for long. The main stream of it has been implemented only recently in February 2026. As you can see, most of these schemes, of these purchasing arrangements, apart from out of pocket, is mainly through the public facilities. So there is a limited leverage of private sector, while we know very well that in country, we don't have the public sector network of facility in all the areas. So we have a part of the population who cannot benefit from all these programs because there is no public facilities where they live. Next. So currently, and based on the design of those different purchasing arrangements, there is a good coherence on how the purchasing mechanism are working in Burkina Faso. But with the evolution of each of the scheme, we need to sit and think of for the future challenges that are coming. As mentioned, Ramu is very recent, started only in February, so currently covers only a few regions, but is planned to cover the entire country. And as Ramu will grow and will operate, there is a risk that so we have overlaps with the gratuité program. The gratuité program was designed to focus on children under 5 and pregnant women, but very it's expanding based on the current situation, the need of the population. There is a plan to expand it to NCDs, the elderly, the war-affected group, gender-based violence, and those additional groups and services are already included in the package of Ramu. So there is a risk that we have an overlap between Gratuité and Ramu as both schemes are evolving. So it's important for the two ministries, as we mentioned, those two schemes are run by two separate ministries, the Ministry of Health, the Ministry of Labor. So it's very important for those two ministries to ensure that there is a coherence as the different scheme is evolving, is growing. The other element that we have to take into account as a future challenge is the reduction of donor funding. As we said, Gratuité was designed to complement the pre-existing free services, which were generally priority programs funded by donors. Now, with the shrinking of this vertical program purchasing, there is a risk that we will have a gap for those services. So it's important for decision makers to think about how to cover this upcoming gap. Should we integrate those priority programs in Gratuité? Should they be moved to Ramu? Both options have fiscal impact, but also we need to make sure that there is coherence between all the mechanisms in place when we decide where to move the services which are currently funded by the donors. Another element, the last one I want to talk about is the private sector. We know that the public network doesn't cover the entire country. So there is a equity issue for those schemes, those who are supposed to be universal, and even those for specific group. It's important to have all the citizens, all these residents benefiting for those programs. But because the programs are restricted to a certain type of providers, there is an equity issue. Not all everybody benefits from it. So it's important to think about how to leverage the private sector. And in addition to equity, I think leveraging the private sector can also incentivize the population to enroll onto the Ramu, which is very nascent. As a human being, I think everybody will ask himself, why would I contribute to a national health insurance scheme when I live in an area which is not covered by this scheme, where there is no provider who will be able to provide services? So I will have to pay for the national health insurance scheme and pay also the private sector to get care. So those are a set of questions that needs to be thought through to ensure that there is coherence across purchasing arrangement and make sure that they are fiscally sustainable. Increasing the benefits package amid a huge debt is something very important to talk about. Thank you very much.
Excellent. Thank you so much, Marjan. I'm glad the connection stayed throughout. Great examples of both some benefits and some nice features of design, but also some serious challenges coming up for coherence in the future. Great. So, and please, as a reminder, please keep putting your questions in the Q&A box if you have them for Marijan or our upcoming speakers. We will try to answer as best we can there. So without further ado, we will move to Kenya, and thank you very much to our partner and colleague from KenMarine Wellcome Trust Research Program, Jacob Kazungu. Jacob, over to you.
Thanks, Nathan. I think I will put off my video also to conserve my bandwidth, but we'll be speaking through it. Next slide. Yeah, so we'll talk about the Kenya's healthcare system just to set the stage, and then we'll get into PHC, purchasing coherence, and the current developments in Kenya. Next slide. Yeah, so just a brief introduction to the Kenya's health system. So since 2013, Kenya has operated a devolved system comprising of the national government and 47 county governments. And health services is one of the devolved functions in Kenya, where for health service delivery, county governments are responsible for operating primary and secondary facilities, as well as employing human resources to manage those facilities, whereas the national government is responsible for developing national policies, setting norms, as well as managing national referral facilities. So the Kenya's health system is tiered with the primary care delivering, care from the community level and across level 2 to level 4 facilities, which are structured into primary care networks, in which several level 2 and level 3 facilities are linked to a level 4 facility. Next slide. So when you think about purchasing for healthcare services in this context, for the primary healthcare level, there are two main purchasers. So the Social Health Authority and sort of the county government, the county departments of health. And looking at social health insurance in general in Kenya, Kenya has had one of the oldest social health insurance systems in Africa. We had the then National Health Insurance Fund, which was established in 1966, which underwent several reforms over the years, transitioning it to the Social Health Authority in October of 2024. So one of the key problems of the then NHIF was fragmentation. As you can see, at some point, it had over 200 schemes, and some of these, had different as well as incoherent provider payment mechanism. So following reforms over the years and its transitioning to the Social Health Authority, three funds were created. So the first is the Primary Healthcare Fund, which is universal and benefits all Kenyans and finances primary healthcare services across level 2 to level 4 facilities. And then we have the Social Health Insurance Fund, which benefits all SHA registered members and finances inpatient and specialist outpatient and inpatient services beyond the primary care level. And then we have the third fund, which is the Emergency Chronic and Critical Illness Fund, which again benefits all SHA registered members, covering emergencies and chronic illnesses across facilities. Next slide. So looking at payment coherence for primary healthcare in this setting, so the Primary Healthcare Fund finances comprehensive primary healthcare services across levels of care up to level 4 facilities, largely covering preventive, promotive, and curative services for all Kenyans. This is a tax-funded fund, with revenues generated from the general taxes. So primary care providers are paid through a provider payment mechanism called global budget capitation, in which a tariff of Kenya shillings 900, slightly over $1 per member per year is set. And then facilities are paid based on the catchment population for each PCN, which the amount is adjusted according to the facilities' reported service utilization rates. The tariffs are calculated, most of the tariffs reimbursed by SHA are calculated using ingredient-based costing approach. And this includes components such as staff time, drugs, consumables. But the good thing is now these tariffs are standardized across providers. So both public and private providers receive the same rate. So the key thing here is that while the SHA tariffs also include staff time, the contradiction is that counties pay staff salaries monthly and provide other support, including health products and technologies, as well as operations and maintenance costs. So, so that's a point I will take into the next slide to just delve deeper into some of the barriers as well as opportunities for improving coherence. Next slide. So how do we best address some of the barriers that exist while looking at what opportunities we have to enhance coherence in this context? So the first barrier, while we're cognizant of the fact that there could be double payment to providers, so in the context that SHA reimburses providers costs for services, and the costs often includes staff time. So even though the staff time as salaries are paid by counties, so perhaps this might require a bit of an in-depth interrogation, but we're also cognizant the political landscape might be challenging for that. Second is the introduction of new schemes such as civil servant schemes that might bring back fragmentation and incoherence in the provider payment. But those notwithstanding, we still have opportunities for improving coherence. So first is the Facility Improvement Fund Act and its implementation. So Kenya passed this FIF Act, which promises to enhance facility autonomy, making sure that funds actually reach the facilities that are intended to, and facilities have the opportunity to use the funds for priority services within their facilities. Second is the fact that each county government, has ability to make the decisions on PHC funding, and therefore there's an opportunity for new solutions to emerge. For instance, we've observed, changes around commodity security in some counties, such as Trans Nzoia, schemes coming up across counties, such as Murang'a, amongst many others. So that's promising to show some of the solutions, ingrown solutions that counties are really leveraging. And then SHA is rapidly developing. A new provider payment mechanism will continue to evolve. But the good thing is that this political will to transform SHA, which means the ongoing reforms that are ongoing at SHA remain a government priority, and that provides an opportunity for enhancing coherence in the future. But the bottom line is that the PHC remains underfunded, and therefore the government needs to improve funding to this. But there is time to improve coherence in financing for primary healthcare in Kenya. Thank you.
Excellent. Thank you so much, Kazungu. Really appreciated that, especially maybe really diving deep on the payment incoherence, if you call it that, across funding schemes. So thank you very much. Okay, we'll now move to Indonesia, where we have the great pleasure to have Professor Hasbullah Tabrani join us today to talk about coherence for purchasing in Indonesia. Prof, over to you.
Thank you, Nathan. Good morning, afternoon, or evening, all of you, wherever you are. I would like to share a little bit Indonesian experience. Could you next slide, please? Yeah, the Indonesian health system currently most popular is the national health insurance. We call it JKN, similar like SHA in Kenya. That is integration. Previously, prior to 2004, we have social health insurance schemes. We have national social assistance scheme. We have regional, provincial, and county social insurance scheme for low-income people. But in 2004, we came up to integrate into a single pool at the national level. Although the law passed in 2004, but the actual implementation, because of the political battle and awareness, approval, people, and so on, we started to integrate in 2014. That's become single payer for the so-called curative or individual healthcare. It's cover comprehensive healthcare. We call it as medically necessary cover. Next slide. It is under the National Social Security Scheme. At this time, we see the on the left graph showing the percentage of people already registered. The scheme of the JKN funded by mandatory contribution, 5% of salary or equivalent for formal sector, subsidized for the poor and low income, and option of 3 choice for the informal sector. On the right graph, you can see the decreasing out-of-pocket payments at the beginning when we introduced the national insurance. It's still 45%, but nowadays around 30%. Still not achieving the target of the WHO. Sustainability remain concerned because of the increasing awareness and people who did not use before getting trusted the system and using this system. Next slide. So if we look at the the overall, we have source of fund, which is the JKN on the very left with the benefit comprehensive, outpatient, inpatient, and so on. For the primary care, the benefit covering GP visit, diagnostics, medicine, and referral to referral care. Funding is payroll, as I mentioned before. The provider payment we use for the primary care prospective payment, adjusted capitation, adjusted by age and gender. The provider, people choose the provider they want to use. the primary care, either public or private. We pay the public a little bit less, the private around 40% higher to compensate fund channeling for salary from the county and the Ministry of Health for the public health center. So it is governed by a National Health Insurance Agency called BPJS. The Ministry of Health and regional governments responsible for paying preventive and promotive care in the primary care level. So that's the mandate, the separation. But in reality, there are some blur, yeah, in the between. That's becoming an issue. Yeah, for example, for the TB, a little bit conflicting which one the borderline preventive and curative. They've been reformed, this one, by the Ministry of Health to integrate primary care level. We call it integrated primary care. In Indonesia, we call it ELP, Integrasi Layanan Primer. Yeah. The operation primarily by public health center, we call it Puskesmas, at the sub-county or sub-district level, and below that, at the village level, they are also sub-health center. Government funding by national for the program, but operation by regional government. Above that, we have out-of-pocket. People pay directly for non-cover services, non-procedural, not cover, but non-procedural, and by using other providers like dispensary or drugs of choice, yeah, if they want to have a choice. And some in the public center also they pay a bit. Next slide. So our currently idea of integrated primary healthcare services that responsible by government in terms of promotive preventive and the national insurance. There are some thinkings about reforming primary healthcare toward fully prevention and population health. That's under the discussion to ensure not many duplication, to ensure coherent environments, but still these issues still under discussion because also growing NCD burdens, the also free healthcare screening that's currently being undertaken by the Ministry of Health and nationwide to ensure that we have a mapping of individual risk profile, while capitation also cover the logic thinking. Then we have next slide. Yeah. The barrier to coherence, we have a problem constitutional and legal. We have several regulation stipulating payment and source of fund from national, regional government, and some program that's becoming a little bit complicated to make a coherent payment altogether. The other one is the political economy because of the continuous deficit of the JKN, the national insurance, debate on the sustainability and require cost control and contribution increase becoming big issues because the government afraid if we increase the contribution to ensure no deficit while increasing spending on especially national NCD. That's become a hot topic at this time. And also in the institutional complexity, since we have this referral system um, for secondary, tertiary care must be referred by primary care doctors. The primary care doctors often, because they are paying capitation, they have incentive to send the patient out, and it become more expensive at the secondary level. So that's kind of complexity. The reform under consideration is the redesign the JKN payment at Puskesmas, because that's considered not efficient, because that duplication, some funding from capitation from national insurance, and also from Ministry of Health, and from local governments for salaries and all the operational costs. That's becoming an issue, but we are still formalizing this blend payment. It's in the process that HSI is supporting the Ministry of Health. Thank you. I think that's the pinpoint. Yeah.
Thank you very much, Prof. Much appreciated. And thank you to all three speakers. I know we have asked you to share content and thoughts that could easily take an hour or more and condense those very, very quickly. So thank you all very much. Um, Great examples of the reality of mixed purchasing arrangements in countries, and some good examples of things that there's some thoughtful design that is working well from a coherence point of view, and others that are real challenges, potential losses of inefficiency, losses of efficiency, etc. So let's move now into the so what of our webinar, and I'd like to very briefly share a framework. This is probably going to be familiar to many of you, but I think can help structure kind of what we've heard from the country presentations and the panel dialogue coming next. So next slide, please. So next slide, please. Let me start by saying that I'll just continue speaking. I think we may have a delay in the slides. There we go. Great. Oh, you know what? I may have passed a poll. My apologies. So I'm asking my team, correct me. Don't be shy. If we skipped that poll that was happening, or can we? Yeah, right here. Apologies. We had a little delay in slides there. So before we move to the next part, we do want to hear again from you. You've heard many examples here from these countries. Thinking about your own context, is improving coherence primarily a technical, or meaning a public health or economic design kind of question, or political governance type issue? So get a quick poll on this, which will probably be an issue that comes up in our panel as well. Okay, let's see what our quick results look like. Yes, okay. The distribution there definitely skews toward the political a bit, but plenty of technical challenges as well. Okay, so let's keep that in mind and we'll keep moving. Next slide, please. And next one. So we are definitely seeing similar coherence challenges across quite different contexts from Burkina, Kenya, Indonesia. And the challenges that we kind of heard are a lot of questions about coherence. So who should be covered by which mechanism? What are the incentives across different payers to the same providers, etc.? There is potential for some value-adding complementarity, such as cross-subsidization of a priority population or patient choice, but also lots of potential for value losing, if you will, incoherence that can come from direct financial, administrative, patient-centered inefficiency. We know there's losses in efficiency and equity as pools get divided up. I saw there was a question about how this relates to pooling. And complexity can make dialogue quite difficult. So, next slide. We would like to propose, based on lots of literature that has been written and experience that has been gained by many people about purchasing and coherence in purchasing. We would like to propose to think about a simple framework of 4 Ps. So that includes thinking across purchasers, not just within one, about the package, what is being purchased, the people who is being covered, the providers, which providers are engaged, and payment, how are providers paid. These are 4 well-known strategic purchasing questions, and we think when you think about coherence, asking them in a unified way across multiple purchasers can be quite helpful. I won't dwell long here, but I do want to credit, and you'll have these slides later, a large literature on this. I've put 2 of many that I could have put citations on the bottom there that are great additional resources for those that want to dive into this more. I'll also note that some of that literature, the second one there by Cashin and Gautam Munua, also discuss a fourth or additional 5th P of performance monitoring. But for today, if we just think about these 4 Ps and go to the next slide, you can think, for example, about how to use this as a discussion tool. It's definitely not a blueprint for assigning fixed roles. This table shows, just to read off the top row, how you might ask related but distinct questions about a package of services. So what services in that package are funded by the budget? Which ones are included in a benefit package of NHI? Which are donors or vertical programs prioritizing? Which is offered by the private sector? And what kind of coherence questions exist across those that might be ripe for some policy improvements? Are the offered services across those purchasers supporting health system goals across sources? And I'll save time by not reading through the rest of this, but similar types of questions can be asked across people, providers, and payment. The next slide, which I'll go by very quickly, is a similar thing, but thinking about a particular package of services and thinking what does that look like across the remaining 3 Ps. So again, you'll have this when we share it later, but we've done a bit of a stylized example of that using I would call it a Kenya-like case. Okay, next slide. Great. So we hope that thinking about this framework helps make purchasing interactions across multiple purchasers more visible. We think that that might be a useful tool actually in dialogue with policymakers, and hopefully it's useful as we think about our panel discussion that we will come to next. Okay, so just before we do that though, very quickly, we also want to hear as we start thinking a little bit more about the governance challenges. In your experience, how well do the most senior policymakers and politicians in your country understand these issues of coherence? We'll give you a few seconds for that while our panelists get ready. Okay, great. Let's show those results. Oh, I'm not sure the poll opened. Sorry about that. You know what? For the sake of time, I really do want to move to the panel, so we'll skip the poll, but the question is now in your head. So thank you. And let's go to the next slide. And I'm very happy to introduce this great panel. So it will be moderated by HSI's Philippines Country Director, Pee Wee Ko. And we are very privileged to have join us today Chris Atim. He's currently a Senior Technical Advisor to the CEO of Ghana's National Health Insurance Authority and an expert in many other ways. And Eduardo Banzon, Director of Health at the Asian Development Bank, and himself an expert in many of these issues across many countries. So with that, thank you, and over to you, Pee Wee.
Thank you, Nathan, and thanks as well to our presenters for those rich country examples. And as Nathan highlighted, despite the very different context, similar coherence challenge seems to emerge across countries, such as fragmented incentives, overlapping financing arrangements, and difficult governance questions. Perhaps the audience can also continue to answer the last question in the chat box. But I'm very pleased to welcome my two panelists who will help us reflect further on these issues. So again, I'm joined by Dr. Eduardo Dodo Banzon, Director of the Asian Development Bank's Health Practice Team, who brings 3 decades of experience in health financing and universal health coverage. And also delighted to welcome Dr. Chris Atim, Senior Technical Advisor to the CEO of Ghana's National Health Insurance Authority on free primary health care. So thank you very much both for joining us today. And so to our panelists, we've heard today how countries are navigating multiple financing arrangements that often operate alongside one another, but not always in coordinated ways. And through the country examples, we've seen how these arrangements can shape incentives, provider behaviors, and access to PHC in very different ways. So let me start with a broad reflection question from both of you. How much do the experiences we heard today on managing fragmented purchasing arrangement resonate with what you see in Asia and Africa? So first, maybe Doc Dodo can answer that question.
Thanks, Pee Wee. And I'll probably respond by picking up I think what that was the Kenya presentation, right? Maybe we're trying to see a problem when there's none. So in a sense, for me, I rather have, because when we start talking about this, how do we call this multiple streams, right? In Asia, it's less a problem of what Burkina has, which was a scheme which is both coming from the government budget and, in a sense, use the government budget to you put additional scheme in order to incentivize or make sure certain services are provided. So the gratuity, but more of having government providing a budget to the supply side than having insurance. And then we start saying, that's a problem. There's an incoherence. Well, it's a question is, I will always say, is why was it done, right? Because if national health insurance refused to pay primary care, and there are countries in the region that decided not to do that, which still continue to just do hospital care, then there's a big push for them to start paying for primary care, and we've seen that, and of course countries like in Indonesia, Hezbollah, Philippines, and others have responded. So you start thinking, why is it the way? Well, for me, frankly, it's because that the supply side or the budget line item side was not delivering on what it was supposed to be doing in primary care. And countries that basically say, look, we want to have our insurance pay for primary care, it's because we expect to do that job well enough. And so we just let the health insurance do hospital care. So in a sense, I see it in that light rather than two stream of money inefficiently spending for the same services. The way the money flows anyhow is different. One is basically just pay for the inputs, paying for capital investment, paying for salaries, paying for the medicines, which unfortunately we know because of the way if you use budget to pay for medicine, there'll always be delay. There's always be supply chain problems, delivery problems, and all that. And so for these countries, the ability to, for example, to provide some PFM flexibility at the ground level so they could actually buy the medicines on their own won't be provided if you're getting that money from a line item or budget. then health insurance could provide you that flexibility. And health insurance basically pays not for inputs, it pays, you get cash. And frankly, you could use the cash for whatever you want. Right? When you get the cash, you're not going to say, I can only use this for primary care. That's not how it's usually done. It's usually the challenge to make sure that money stays with the primary care provider, because the risk is that that money is going to be grabbed outside of the health sector, which we're seeing in the Philippines, less in Indonesia. So I don't really see this as an inefficiency, but rather I'm so excited because more money is actually flowing down to primary care. And I rather have this than have a system where the national insurance only pay for hospitals. And so at least in Asia, we're seeing a lot of enlightened national insurance now paying for primary care and creating this inefficiency that people are now, well, we're talking about now, which for me is not really the problem anyhow.
Okay, thanks, Doc Dodo. Refreshing as always. And Chris, would you
Hi.
also answer the question?
Thank you. Thanks. Yeah, hello. Hi, Pee. Thanks so much. Yeah, I very much align with what Dodo just said. It's I do think what's happening is that most countries find a new insurance mechanisms or UAC schemes that they set up not replacing the old line item budgets. This is really what we see in Africa, but layering on top of them. And that causes some of the frictions and the coherence that we see. They layer on top of existing, because of existing schemes as well, because there is, they might utilize the path dependence. There's resistance to changing the way of doing things that exists. There are vested interests, and they don't want to see a change. So you layer on top of them, and that creates some kinds of friction between the desired goals and the institutions that you actually set up. Ghana has been a good example of how we're moving actually from a situation where these contradictions existed towards a more coherent future. I mean, I think that the overall trajectory has been one of moving away from the contradictions of the past, the coherence, for instance, the funding, different mechanisms, funding primary health care, one funding the curative care, and then no funding basically for extremely expensive diseases, towards consolidating them to now two big pockets of money that are doing those. It's not yet one single pool, but there's two big pockets of money now that are handling, primary and sorry, I don't know why. I think primary and curative care in general, and then the high level NCDs and other expensive diseases. Two different pockets of money. That's some progress with respect to what used to happen in the past. So that's, I think, I think that's important to recognize. The other thing is that, for me, the most incoherence, comes from countries which have adopted an approach where they have different schemes for different population groups. I think the classic example is Gabon in Africa, where there's one scheme for the formal sector, one for the informal sector, and another for indigents. Now, that's the classic example of when the government decides to start these UHG schemes to the line of least resistance, because that's the easiest way. There's no cross-subsidization or resource pooling between these three at all. And that's a very classic example. We also have Senegal and Mali, which are, again, illustrate the point I made earlier about path dependence, where in the past, at the start, they had these community-based health insurance schemes, which when they were developing at the time, actually were a massive improvement over the previous situation. But in the course of history, their development, they have had to fight against inappropriate forms of control from the government, and that has limited the options for integration. So now they don't actually have integration. They have these multiple schemes and so on. And that continues to be a handicap in the way of developing more coherent and larger pools, in order to take to confront the challenges of health financing that they face. We have other challenges as well. Interministerial collaboration. I mean, I think the example of Burkina, where the Ministry of Labor is in charge of the gratuity, and then the Ministry of Health is in charge of health, priority setting, is an example that is not unique there. I mean, I've worked with that in, for instance, Cote d'Ivoire. I saw it in Togo. Togo, though, they resolved that more in a way that was, I think, more towards coherence. But in the case of Cote d'Ivoire, it remained a big issue in terms of one ministry is, running the insurance scheme, another one is setting the health priorities, and there's no necessary mechanism to ensure that the two actually are aligned. The insurance scheme has an incentive to pay for what is lowest costs, because they don't want to have deficits, and so they not necessarily choose to fund the kinds of services that might lead them to have deficits. Whereas the Ministry of Health wants the health priorities of the country to be the focus of funding, and that necessarily doesn't happen. So you have these misalignments, and I think that fundamentally they arise from a governance challenge of how do you ensure that there is coordination, alignment, and an institutional arrangement for ensuring that there is coordination and alignment, and a method of ensuring that the potential conflicts that arise from this are resolved amicably. These are institutions that don't exist in many of the African countries. There are many of Ghana's neighbors actually having these kinds of problems of institutional misalignments, and that makes it very difficult for them to move towards integrated, health financing schemes. Thank you.
Okay. Thank you very much, Chris. Actually, so I want to further explore some of the themes that I think both of you were saying, and maybe raise one of the questions already put in the chat. John T actually put in that traditionally our understanding is that larger risk pools means less fragmentation is actually more efficient. But how much fragmentation of risk pool is actually considered acceptable or efficient? I think Chris was also pointing to some problems in terms of misalignment. For example, when separate benefits are given to separate population, there's problems in terms of equity. And then I think the other thing that Chris was also pointing out was that sometimes when you already commit to a design, there's already a path dependency in terms of actually pushing forward with that scheme. So maybe first, Dodo, just in terms of this, if you can share your thoughts in terms of maybe further challenging what our current perception is in terms of actually ensuring lessening fragmentation, for example. You're muted.
I thought you muted me, Pius. Sorry. No, I'll talk more, because in a sense, this it's like we have a lot of countries in Asia, of course, started where primary care is provided, where government started to provide primary care services. Okay, countries listened to the global move and all that, and then they started expanding that. But then the problems, started coming out. It was hard to provide incentives for health workers, because you have to pay health workers similar to other government. It's not as if you could pay health workers in countries and treat them differently. Probably Thailand can do that, but most countries cannot. And so they started to say, look, how can we actually provide more so that health workers will provide services much more than. Then, of course, we saw the problem how the longer you are, sometimes in government with tenure and all that, you tend not to incentivize to provide better service. Because if your services becomes, you don't give the right service, you're still going to be retained anyhow. And we started to see there were problems in supplies and all that because of the general. So the scheme before was to put in performance-based payments and all that. usually used with donor, but unfortunately, when the donor money stops, government cannot absorb them because the PFM rules, the public and financial management rules of governments in Asia, could not be revised in a manner that was how the donors has designed it, where you provide performance payments and all that. Now, health insurance provides you that, because health insurance does not pay for inputs, it's paid for services. Health insurance, basically because of the nature of how it's designed, paying for services, the money then, if it is retained somewhere, usually you find a way that it can be provided as additional compensation for health workers. It can be designed to pay for performance. So I don't really see much incoherence. I actually see that these are both complementing, have the same objective. You just need to frame the story better, get them to work together. And if there's incoherence, it's because probably it's more of the leadership between the Ministry of Health and the guys running the health insurance. But that's not difficult to solve. So in a sense, I don't really see this as a problem of incoherence or inefficiency. I'm even happy because more money, which if it doesn't go to primary care, would have been used to pay for hospital services anyhow with the health insurer. So I rather have that money go and pay for primary care. So that's probably how I explain. But health insurance also cannot pay for a lot of things needed for health services. It's lousy to pay for salaries for staff. You could never get enough of that money to pay for staff, and staff needs tenure, unfortunately, and you need line item for that. It's never good to pay for infrastructure, for equipment. Because the way a lot of the schemes are usually designed where the amount of money you pay will never be enough. So in a sense, you look at this as two system that works together, and stop framing it that you need to. Now, of course, if you are a country that can actually pull both of this money in one fund, that would be great. But unfortunately, never happened in Asia, not that I'm aware of. So in a sense, given that the path that these systems went through, and they actually were path dependent because they all have their own history. So the fact that we're actually seeing this now work together in Indonesia, for me, Hasbullah is a great story how it's working together. So those are nice problems to have, but I don't really see them as a inefficiency, or it's actually great mobilization of more money for primary care that we're seeing in these schemes. And Philippines, Indonesia are great stories for me.
Yeah, actually, still aligned to what Jacob also said, that PHTC is still underfunded. So it's also about framing it in terms of actually adding more money for health. Chris, how about you?
Yes,
What do you
indeed.
think in terms of where those misalignment?
I like the
happen?
nuance.
Yeah.
I very much like the nuance that this implies, in that it is not a straight jacket. You can't just assume that less fragmentation is always the way, always brings the best results, because it can actually be perverse also in certain circumstances. I mean, let's give two examples where that can happen. We are now looking at vertical programs, integrating them into national financing schemes, which is a very good principle overall. However, one risk of that is that these vertical programs were extremely good at targeting their population groups. It's not clear that these insurance schemes have the same capacity or even have the same incentive, because they, for instance, I mean, one scheme in Cote d'Ivoire, to give another example, they are enjoined by the regulations not to have a deficit. They can't have a deficit. So what is going to happen if they take over such responsibilities without additional budgets sufficient for them to cover all those groups? What would happen is that the population groups would actually suffer. And also, they don't have the same capacity to identify, to know these groups well. And this, and also these groups have their own lobbies and whatnot, and they know how to work with under the previous arrangements. They don't have the same power within these other national structures to be able to lobby for their interests. And they might actually feel themselves as losers. That's one example. An example where that can happen. In the case of Ghana, where I think we had a little bit more fragmentation, but it's the good thing overall, which is that the National Health Insurance Scheme was a single purchaser, still is in many ways for its package. But the National Health Insurance Scheme was not paying really for outreach services. So really primary healthcare was neglected. You may expect the core of it. And it was not paying for high cost illnesses, even though the law enjoined them to do so. because of sustainability, they were not doing so. They actually excluded certain diseases quite openly. It wasn't actually a secret, you know. And now the government comes on. See, policy is what? Policy is the outcome of both technical and political processes. In this case, the technical process is that, you know, any additional funding should just go to the NHIA to fund, you know, any additional services. But the political process, you know, that led to this, you know, could only make it feasible if a separate fund was set up. I'm not going to go into the details of that. Only a separate fund could actually make it possible to fund the higher level diseases. Now that separate fund has different sources of income, apart from the traditional ones that were funding the NHI. So they are bringing additional money to the system, and they are covering people who were not covered before. Those are good things, you know, irrespective of the fact that it actually created a bit more fragmentation. So I'm saying this is not a straight line thing, and I agree with the nuance that, you know, we have to be careful when we say, you know, integration, single pool, and so forth. It isn't always necessarily the best thing in the circumstances. You know, and I emphasize again, path dependence is a very important, you know, issue. Thank you.
Thank you, Chris. I think still aligned with what Dodo was also saying, and reframing this as also something that actually adds to how much we're paying for PHC. But I guess the other question is in terms of managing the politics of things, how do you then get these different schemes to actually ensure that they're working together, that they're trying to align in how they're paying things? Chris, I think you were also pointing out that some schemes are actually still underfunded. They still need to improve in terms of financing. So how do these different schemes actually work together to ensure that they're improving in a coherent way? Maybe Chris first before Dodo. So Chris?
You're asking how the underfunding can be addressed by these.
How can they be addressed, and then how can they be improved in a coherent manner? How do you then get them to sit together with all the politics?
Okay, I can illustrate an example. Some of the arrangements that we have actually do increase, of course, the inefficiencies in the, you know, arrangements we have, the incoherent, you know, schemes you have, actually lead to the deficits themselves. Not always, the deficits are not always an outcome of money not being sufficient, in principle, to cover the services that are required. Often they are the outcome of highly inefficient ways of operating. An example of that was, if you look at, for instance, if you look at the, again, to use the Ghana example, the Ghana public sector is highly utilized. Its capacity, is highly underutilized. I mean, we went to the World Bank when they did a PAR study a couple of years ago, they found out that about less than 30% capacity was being used in the public sector. However, the NHIS, the Ghana Health Insurance Scheme, pays higher rates to the private sector to actually provide services. I mean, and just imagine that. Often it is the same practitioners in the public sector who own the private, facilities. So they are paid higher to go and provide services in the public facilities when there's under capacity in the public sector. That is a clear inefficiency, without a doubt. I like the Burkina example, and it's one that we recommend in Ghana. I don't know, it hasn't yet been implemented, which is that the private sector should be leveraged to support the underprivileged areas. Where there's under provision, where there is no competition, for instance, if you have competition as your payment method, you want competition, to give people the right to be able to choose, a different provider if they are not satisfied, and if you don't have that, then really you are not getting the maximum from your competition. So ensuring and incentivizing private providers to set up in those areas to provide competition and to provide more services is a very good, policy. However, where in the capital city, Ghana, and the other big suburban centers, we have so many private providers, and they are all on the insurance scheme. I mean, what is this public health justification for paying so much money to people who are not really, it isn't really essential to have all of these providing services, and even worse, pay them higher rates. You could come into the scheme under the same terms as the public sector. Then you have the faith-based organizations, which is in between. They are paid a little higher than the National Health Insurance Scheme, but less than the private for-profit schemes. So, and even that is a contentious matter for the public sector, because the public sector says there's no difference between them and the faith-based organizations, because also the salaries of the faith-based organizations are paid by government. So what is the reason for the different rates? And these are areas that it is arguable, there are inefficiencies that lead to some of the deficits that we see. And so actually rationalizing this, ensuring that the capacity in the public sector is utilized, and that you leverage the private sector precisely to be able to improve, the service delivery and service to the population, and not simply to squander resources, scarce public resources, on unneeded, services. To just show an example of what some of the perverse effects, because the public sector in Ghana doesn't have autonomy to make decisions like the private sector. When we had capitation as an experiment in one region, we went there and we found out that you go to a private facility and the private facility is doing everything to attract clients, including providing breakfast to clients, to patients. Whereas the public sector cannot do that. They have no autonomy whatever to do that. So you go to a public facility where they're having 4, 5 or less clients a day, and you go to a private place and they are over, there's a huge queue. They can see everybody in the same day. So these imbalances they are created by policies. It's not natural. And they are actually, because you could have put them on the same level playing field to ensure that the private sector can also compete, fairly to attract these clients, but they are not. And so the result is that we're aggravating the situation that, of undercapacity utilization, of the public sector, and actually overcapacity utilization in the private sector, and paying far more than we need to. These are some of the examples of how you can, actually, there's room for rationalizing to actually use the limited resources in a way that it can go further than it currently goes. Thanks.
Thank you. Thank you, Chris. A lot to unpack there. Doc Dodo, how do you get the Secretary of Health and the President of Insurance to sit together?
No, I'll step back a bit, Pierce. It's like, okay, at the end of the day, what do we really want to harmonize? If you want to use the word harmonize, right? What you really want to harmonize is the primary care services that everyone gets, right? And if this is where there's a focus that would be done, that means this is the job of the Minister of Health usually, right? So basically they should say, okay, look, for my country, when we say primary care, it means you should be getting all these services from vaccination to diagnostics and all that, right? And how that's going to be provided, then in a sense, even if you have, let's say, one single pooled scheme, that's the easy, hopefully you have all the money to do that and the flexibility, then you could provide that. You make sure everybody gets that services. We know that doesn't happen. So then that's why you now tap with other sources. So for example, health insurance. If your health insurance is like Philippines or Indonesia, single fund, and that's easier thing to do. All you have to do is talk to JKN. Maybe Hasbullah can talk to JKN, and Hasbullah can also talk with the Minister of Health of Indonesia. Now, if you have multiple schemes, insurances, then in a sense, you use this fact that you have a nationally mandated primary care benefit that everyone should be using and make sure that that's being provided, including getting the private sector to behave. So when we start, and I actually like the private sector to be involved, because if they're not in the scheme, they will provide lousy whatever services they will provide and charge you whatever they want to charge. Getting them into the scheme, whether you're paying them more or paying them less, but in a sense, you're contracting them now, you are making them accountable, that those that are assigned to them, because most countries usually use capitation, will be getting the same floor, the same level of primary services that's mandated. So for me, that's where the harmonization should be done. And that's what countries have not really done well. They have basically a lot of what is primary care is implicit. Whatever services already be given, then the insurance probably will enlist. What you say, okay, look, when we talk about primary care in our countries, this is what everyone should be getting, and then we'll try to find a way that it is provided, whether public or private, local or national, and in a sense paid in various ways. or whether if it's a single fund, great. If not, then we'll make sure they all work together. So that's harmonization for me, Pierce. It's at the packages level.
Okay, perfect. And I wish we had more time, but unfortunately, we're out of time. So turning it over to Nathan for the closing, and let's continue some of these discussions offline.
Gosh, thank you so much, Dodo, Chris, Pee-wee. I really hate to interrupt you because you were on such an interesting role. We're gonna have to plan a sequel, okay? So please look out for that. Thank you all very much. I just have a couple slides. If you can hang on just one more minute. I just want to say, first of all, thank you to everyone for joining us today, to our panelists, speakers from the country presentations, and this latest panel presentation. I think we've definitely seen that this is very clearly an issue across many countries, many mixed health purchasing schemes. I think we hopefully have seen that talking about it in this way, sort of looking at 4Ps across multiple purchasers all together, is a useful way to bring up these coherence questions and hopefully helps with dialogue. And then I think we've only just started getting into some of the governance challenges and political economy informed ways of going about this. We will process all this a little bit more, and as I said, we'll share all the materials, including a very rich Q&A that was going on throughout the whole background. That will also be available on our website later. And I hope you will all join us for our next webinar, which is going to focus on fund flows and some of the inefficiencies that we have seen simply as funds flow from national level down to facility level. We don't have an exact date for that one, but it will either be end of this month or early half of June. So please join us for that third one, and then we'll have our fourth webinar later in June. Thank you all very much, and I wish you all a very great day and remainder of the week. Thank you.
Thank you, Nathan. All.
Thank
Thank
you.
you. Thanks.
Thank
Thank
you.
you. Thanks.
See you next webinar.
Yeah.